meeting to order. Thank you all for coming, and we'll start with some introductions. We can start to my right.
Good morning, Jeff Horner with CalSTAR.
Teresa Rios, EMS Agency.
John Burley, EMS Medical Director.
Will Hiller, AMR CES.
Cole Clayton, Tividad.
Chomp Christy Sobleski, Chomp.
Nick Green, Salinas Valley.
Scott Hopkins, Salinas Fire.
Dave Craddock, paramedic.
Laura Wallen, EMS Agency.
Silas Fisher, Monterey Fire.
Roxanne Simpson, EMS Agency.
Tom Woodland, EMS Agency.
Kirby Walton, CCF Fire.
Ben Hitchcock, AMR CES. Carlos Vega, Control Fire. David Tenovich, North County Fire.
Jared Ivo, EMS.
Hello, Jared. Thank you. So welcome again. Thanks for being here this morning. I'd like to open up the meeting with an opportunity for public comment. So hearing no specific public comment, we'll move on to the next agenda item, which is approval of the past MAC meeting minutes. Can I get a motion for approval?
Motion.
Okay,
Second.
second. All in favor? And opposed? Okay, so the meeting minutes are approved from our last meeting in January. We'll move on to EMS recognition and correspondence, of which we don't have anything specific listed there, which brings us to old business and the Epi auto injector EMT basic scope. Steve, you have something for us?
Good morning. Based on previous discussions, this body has been looking at the use of auto-injectors with epinephrine for anaphylaxis used by EMTs and emergency medical responder trained personnel. The big issue so far has been the issue of cost. We have contacted AMR and found that AMR is able to use their cooperative purchasing power to bring epinephrine auto-injectors at a cost of about $59 a unit. However, it requires 30 auto-injectors in order to get that price. So we have, we're bringing before you the policy, EMT scope of practice. We will also bring the EMR scope of practice a little bit later as we discuss naloxone. But at this point, we're looking to have endorsement of this group representing the EMS system to say, yes, we would like to have epinephrine auto-injectors on our BLS units so that we can more readily respond to the emergency of anaphylaxis. At this point, if there's any questions.
So, hearing no specific questions or comments, do we have a motion for approval?
I motion to approve.
Thank you. We have a second?
Second.
All in favor?
Aye.
I should add one thing. We're looking for a July 1 target date to allow ramp up for equipment as well as trainers.
Perfect. Thank you, Steve. Which brings us to new business. And the first item on the agenda there is under opioid overdose, naloxone leave behind program. Tom, you have something for us?
All right, good morning, everyone. Just want to go over a few things about this potential program that we would like to bring as part of the EMS agency. It's a naloxone leave behind program. It's currently a pilot program in San Francisco, but currently Monterey County is experiencing an increase in opioid-based narcotic overdoses, and really we didn't really hear about it until the unfortunate event of the young 16-year-old girl in Seaside. So the EMS agency, along with other communities and partner resources, began to research ways to assist those who have an emergency overdose event in the pre-hospital setting by providing folks that may decline transport, leave behind the little Narcan, naloxone packages. And in general conversations with providers, it's been pretty well received to this point. If we would be the second LEMSA in the state to have this program, and we're seeking the endorsement of EMCC, and then we will then send it to the state EMSA for approval to move on with the program. Both Dr. Burley and I have been working really hard on this, and I want to give Dr. Burley a moment to comment on this concern.
Thanks, Tom. So you're all probably aware and recall the presentation that Dr. Close gave to us at our last meeting, and I think by now we're all pretty aware of the crisis within the county and nationally regarding opioid toxicity and overdose. And the opportunity came before the agency to assist in reducing mortality of those patients with the use of a program in which we would leave naloxone behind at the scene in the event that a patient would be resuscitated from a narcotic overdose and subsequently want to sign out against medical advice. So this would be an opportunity to leave a life-saving drug at the scene and hopefully prevent a fatal overdose recurrence following the departure of EMS. And so this is something that we've been working on pretty hard at the agency and looking at. It's obviously, there's a multifaceted approach that we have to take and look at it from all angles, but we really appreciate the guidance of Dr. Close and Dr. Grover and the passion that they brought to the program and questions that were raised by this body and others in helping to get this off the ground. So we are pleased to be looking forward to moving forward with something like this. We are going to take it to EMCC, and there's further details that can be discussed as well.
Is there any questions about what we're doing at this point in time? Yes, sir.
So funding for the Leave Behind program, is that grant funded, or is that on the providers to shoulder that?
As of right now, there is a program in place through Prescribe Safe that has collected a grant, so we would be able to get some of this, get the stock from them for the short term. So we're trying to weigh all the options out, make sure that everybody can have these packages available to them for the provider agency.
So then that would be for all transport, all first responder agencies, that include law enforcement also?
I believe, I'm not sure about the law enforcement side. I know that they do get those packages currently, so I'm sure that they will also be involved in that process as well.
And you said which county's doing this now?
San Francisco is the first. They have it's called Project Friend, and they were the first ones to submit to the state for local optional scope of practice for their paramedics to hand this out. And of course, they have a much larger base of population. However, for our base of population, we do have a major increase in this opioid overdose events. So we want to make sure we help out our community the best we can.
I think one of the questions, especially from the agency perspective, is sustainability of it. How do we ensure that this is a one-off and just goes away? Funding for all our departments are pretty tight at this point.
Absolutely.
So I think you have a pretty robust program within Prescribe Safe, and we've been funding and supplying a huge number of folks at this time. You may see funding diverted, obviously, because of the current healthcare crisis we're in.
But it is one of those.
However, at this juncture, they do have secured grants that can supply you guys, I believe, for the foreseeable kind of upcoming future.
Thank you, Dr. Clance. Appreciate it.
Do you know what percentage of people refuse transfer? I mean, is this like 1 in 10 calls, or is this?
So actually, we're just looking at that data here, and so go ahead.
In 2019, we had a total of, based on that data that we were able to pull, 189 overdoses that we responded to. 170 of those were transported to the hospital. That was 90%. And only 10% chose not to go to the hospital. So that is right now that demand that we're looking for. So there were 19 for 2019.
So the probably cost wouldn't be super high, but there's potential for those people who are likely to have another overdose that it could be life-saving.
Yes, and we spoke to Dr. Close and Dr. Grover. They were excited to know that we were bringing the program for endorsement, and they're more than happy to share the Narcan that they have available to them.
There's a few other agencies throughout the country that are doing this, but it's not widely adopted, and so we're excited to be kind of on the forefront, and really want to recognize Dr. Close and Dr. Grover for their part in bringing this to us, and Dr. Linsky as well.
I didn't do it, I'm just a messenger. Those two are amazing.
Tom, I just have a question. How the program is being trialed in San Francisco and then the other agencies as well, what kind of efficacy or results are they finding with the program so far?
We haven't really saw the numbers because it's just recently started, so I'm still trying to collect some of that as well, the data, just to see if it is helping those. I would bet to say that they're probably, it's doing its best job as possible with what they have out there, especially in San Francisco, you know, with the wide population of overdoses in their community, so.
And we know that it's not just handing something and giving resources, so that there has to be a connection to additional services. So we are having those communications internally as well, because we can connect to other county folks. They might be able to provide additional services, do outreach in the areas where we see the high risk, but working with Prescribe Safe, of course, so that we're not duplicating efforts.
Sure, thank you.
I was curious about community education for the program. Does the county have a plan for that?
Our emphasis will be to provide a training resource training for our first responders and personnel, and also there will be a pamphlet to accompany when you leave this behind with resources available for those who need it.
I guess AMR is on board. Our concern, and the only concern, is that people might be coming to the ambulances at all hours of the day and night to ask for Narcan off the ambulance. And I was wondering how is the county going to educate that population so that we could keep our crews safe? And I think there might be an issue too if somebody's knocking on our window saying, I need Narcan over there. Are we meant to go respond and give them Narcan, or start the process?
If somebody's knocking on your window and saying there's a medical aid, then obviously that crew should be calling it in and going over there if that's the case. I think that those are concerns that currently we have not seen anyplace else that have occurred that we are aware of. And
no safety issues at all?
No safety issues currently.
Okay.
Yeah, so for now, I would hope that the crew would just call it in and respond to the call, but again, we have not seen any reports of those type of issues currently.
That is something that we took seriously and looked into, and with other jurisdictions, to see if there were problems that people were encountering. And in general, as Tom says, there were not issues. The idea is that naloxone, it would be so widely available that they wouldn't necessarily have to come to an ambulance. They could get it from multiple sources. Of course, since there's no addiction potential for naloxone itself, that shouldn't really draw people to break into ambulances or in other ways try to get the Narcan.
We're on a Narcan hustle, so.
Well, I think the public have more Narcan than we do right now. I really do. Has there been any follow-up on the backside post, distributing this? Is there a follow-up process where the person gets contacted again, or is it the end of it?
We will be handing out the pamphlet resource to them, and we will be looking at recalls of going back to the same scene, that sort of thing. So we will be kind of tracking that as well, just to see where we stand on that. Currently, I'm kind of hoping that San Francisco puts out some type of a document to the state. Of course, they then post it on their website to see what the reoccurrence rate is, and hopefully we can get some type of numbers from them on those types of issues.
And as Jeff, this is a tough one to validate its efficacy, because these people aren't gonna come back and report, I don't think.
Right, no, I agree.
That's a tough one.
Yeah, I'm thinking it's gonna be difficult to track those people. It's gonna be what you distributed, location, and that's about all you're gonna collect as far as data.
Yeah,
Yeah.
for sure. Absolutely.
Thank you, Tom.
Thank you.
So- Which brings us to our next item agenda, which is obtaining accurate post. Jeremy?
Yeah, actually, that should be under the name of Dr. Nadine Singler, but she wasn't able to make it today, so let's just defer that to the next meeting, and I'll work with her to make sure she can make it.
Thank you. The next item on the agenda is TXA use. Laura?
Good morning. TXA is an antifibrinolytic that's used it's been used safely in hospitals since the 1960s, and there are a number of LEMSAs throughout the state that are using it primarily for traumatic injuries, for uncontrollable bleeding. It is one of these things that if you give it, it helps, and if it turns out they didn't need it, there really aren't any bad side effects. We brought this up at TQuick, and just to kind of get a feel for how people feel about adding this to the scope of practice, and the general consensus was yes. So just wanted to let this group know that we are looking into the use of TXA and adding that to the scope of practice in Monterey County. Is this something that this body feels positively about?
Yes.
Okay, we'll continue exploring it then. Thank you.
Thank you, Laura. And then the next item was quantity of lactated ringers in minimum stock. Steve?
This is simple. I believe it's the last MAC meeting, it was brought up that the amount of lactated ringers in the authorized stock policy was not specified. So as an administrative fix, we've now put in the amount, which is 1,000 cc bags of lactated ringers. It's on the website and will be adjusted in the app. So very simple, we fixed it.
Thanks, Steve. And before you go anywhere, AMR EMT expanded scope application.
Yes. So we have received an application from AMR to provide EMT expanded scope services, both as part of the ALS crew as well as on a BLS ambulance. And they've submitted an application. The application has met the requirements. You will see as part of your packet the checklist that we used. For each section of the policy, we've checked to make sure that they've addressed those issues. If you look at the checklist that's in your packet, you'll see that they've met all the requirements within the application. We're now into the application review and approval phase, which is the second checklist, and you'll see that we are down to the application schedule for discussion at MAC within 90 days of receipt. So we've brought this application to you for endorsement, and then we can move forward with establishing an agreement with AMR, doing review of their equipment and making sure that the personnel records reflect that all the people have been trained, and they will be able to put a BLS unit on duty, as well as staff the EMT position at EMT expanded scope. At this point, if you have any questions related to the process or their application, if you'd like to look at their application, I don't want to print it all for your handout, but I can bring it up if you want to look at anything in particular. If you want to look at any of the policy, we have that where we can show it on the screen.
So you need a motion to continue to approve here, or is that?
I don't see any question.
Okay, no, because you mentioned you're looking for the approval process. You need a motion to approve at this point?
The approval. Okay. The approval process is from the EMS agency. The part of the approval process is receiving endorsement from this body to say, yes, we believe that this is useful, won't we found that there's no detriment to the system, that we find only benefit. Again, we can show what they believe. It's also an opportunity for AMR if they wish to address this body. That's also part of the process. So what we're looking for is, does this body endorse moving forward as part of the EMS agency approval of their application?
I would motion to endorse the process at this point.
Thanks, Scott. And we have a second for the motion?
If I could, does AMR wish to comment?
Yeah, I was just gonna add a comment on this. This BLS unit that we're gonna be establishing with standard scope actually is gonna be really helpful in the system, because last year in 2019, we transferred over 3,800 transports out of county, which actually 311 transfers out of county, which added up to 3,800 hours of lost unit hours of units returned back from the county. When I did the numbers, that was essentially 322 12-hour units shifts that we lost throughout the year, which adds about 20 days that we've lost of these units returned back from out of county. But I haven't done the actual analysis of what type of call it was, but looking at the general data, a lot of them were going to Aurora Behavioral Health, San Jose Behavioral Health, Santa Rosa Behavioral Health, several to Bakersfield, several to San Diego, and of course, returning the patient back home. So that really takes an impact on the system itself, and we have less ALS units available to respond to areas that are actually, saying you don't have anything to respond to. The hospitals have been really good with us to work and try to get these patients out in scheduled times. However, if something happens, like coronavirus or something else, our system is demanding higher needs of everyone. So this is going to be a good add-on to the system. Actually, it is an add-on. We're not reducing, we're actually adding more resources on this. So it's a good process.
Can I ask one thing, more for and everyone? Since you mentioned that the majority of those are behavioral health transports, I know many systems are actually choosing to use a secured vehicle for those transports rather than a BLS ambulance or so, just because of escape and safety routes. Have you guys considered that?
We have not considered that, just because our contract doesn't allow us to do that.
Would that be something that would maybe be a benefit in this
It
setting?
definitely would be a benefit, but right now we have an exclusive contract for the entire county, which means you call, we call. So if it's a BLS patient, ALS, CCT, we have to take it by ambulance at this point.
So maybe we can consider a secured transport vehicle for behavioral health, because it is becoming an increasing issue with patient escape and safety in the back of the ambulance and such. And perhaps that might be something to consider.
And I think some of these patients will have to look into it. I don't know how many of them are actual holds. A lot of them just are going for further evaluation. And I would look at that specifically.
Any other comments or discussion?
Timeframe of implementation then?
As soon as we can get an agreement signed and review of the equipment and review of the personnel records, it could be in place,
Yeah, we already purchased the equipment. We have a brand new ambulance for that that's ready to go. It's actually getting CT inspected tomorrow to make sure that it's ready for service. So we've actually even scheduled some staff just in case everything gets done correctly and before we're ready to start.
The agency would like to move this forward as quickly as possible. So if we can, turn around the agreement, if the ambulance is ready tomorrow, I suppose that might be as early as we could do it.
I think we had a motion and a second. Okay, take a vote. All in favor?
Aye.
All opposed? Great. Motion carries. And then Steve, you had something for EMR naloxone use.
I do. You'll see the staff report, which summarizes the issue fairly well. What we have is at recent MAC, last year, MAC and OPS and everybody really wanted EMTs to provide intranasal naloxone, figuring if librarians could do it. We made that move forward. However, we did not include EMR. EMR is permitted with medical director policies to put in place to do intranasal naloxone as well as epinephrine by auto-injector. So you've seen the policy and endorsed moving forward with epinephrine auto-injector for EMT and EMR. We are now correcting an oversight in moving EMR into the intranasal naloxone world, and that's what this policy is for, and to update the scope of practice of EMR as well as to conform with Title 22 public safety regulations, the policy for EMR optional skills training, which mandates what has to be done to allow the individual and the agency to provide that service. So we're looking for MAC endorsement to include intranasal naloxone for EMR as well as endorse the policy changes.
I have a question for you, Steve.
Yes.
So with EMR oversight, it all falls on the local jurisdiction? I mean, I've been confused how EMR has changed over the years. And who actually provides the regulatory authority for them? So it's all local as far as EMR?
For our purposes, yes.
Okay.
If an agency such as state parks, and I had a conversation with someone who's from state parks yesterday, they are under the state authority because they're a statewide organization, but for our purposes, yes, it comes under EMS agency jurisdiction.
Any other questions or comments?
Just got one quick. I think just in general, there are things where we're not just talking about librarians giving Narcan, we're talking about leaving Narcan with junkies. And that's a good thing. And so anytime we have something that's such a good thing that we're going to leave it in the hands of the most vulnerable population, I think we need to do everything we can to make people able to use that same technology.
Mm-hmm. Absolutely.
So do we have a motion to carry?
A motion to carry.
I second.
Second? Yeah. All in favor?
Aye.
Any opposed? Okay, motion carries. Thanks, Steve. Next on the agenda, we have EMS agency response to COVID-19 updates. Jared?
So good morning. There is this thing called the COVID virus. And the purpose of the staff report was to show some of the steps that the EMS agency has taken so far. I will highlight a couple things and then I guess entertain some questions because there probably are some. Several weeks back, we initiated through the MPDS process some travel screening questions so that the providers and responders would be notified of any potential issues. And we've also provided some guidance in the clinical care, decon, and infection control for pre-hospital settings. And did anybody have any questions on that or anything else related? Because we've also recently instituted or sent out some guidelines on the procurement of supplies, which is probably our first emergency, is that we're already seeing supply chain issues. So we did send a detailed memo out on how that process would work through the MOHOC, which is the Medical Health Operational Area Coordinator through the EMS agency. So that's probably where many of the questions lie today, but if anybody had any questions, I'm here to answer those.
Yeah, can we back up? Like, sure. So how much PPE stuff did the different agencies have on hand?
Not enough?
Okay, like a month or?
Yeah, part of the process was to detail their supply chain issues with those specifics. What was your last PO? What's the expected date of shipping? What do you have on hand? What is your burn rate? Stuff like that.
Okay, well, let me make this simple. Like, if you were to run 50% of your calls in full PPE, like, what do you, just off the cuff, like a month, a week?
I think days.
Days.
Yeah.
Okay, so critical. And who's the AMR fearless leader?
2 weeks for us.
All right,
Yeah.
2 weeks for you guys. What do you guys?
We have 60 days.
60 days.
When we put our orders, we have multiple shipments coming in as well
Okay.
as other access that we have. So,
Okay. So
our
pretty
folks are well protected.
pretty critical.
So,
Okay.
and in terms of supplies to basically masked patients rather than just yourselves, so that as you're coming
Yeah.
into the hospital,
We've taken
how many
steps
days of
forward.
supplies do you guys have?
You know, we've all had hundreds of masks on the shelf that are ready to go, but if we don PPEs for half our calls, we'll burn through those in days.
Right.
I mean, that's really, you know, whether you have 100, a couple hundred, or 500, if the hysteria continues, and everybody's going to, we can't get isolation gowns anywhere on the planet apparently.
Right.
That's where we're really, you know, stuff we've ordered months ago has been back ordered for other reasons, and then this hit, and our next projected shipment might be the 16th. That's the best information we get, but we're only gonna get 10 cases of masks.
Right.
That's all we're gonna get.
And from the EMS agency's perspective, we'll be doing these weekly as things progress, so that we kind of get an idea of what the supply chain issues are, so that we can help if possible. The CDC and CDPH guidelines are pretty much what we're sending out, so we'll continue to revise those as they happen, and that's where we are now with it.
Yeah, I mean, but I mean, like, inevitably at some point it's gonna be in the community with community spread, and we're not gonna be able to do like contact stuff, right? So you just have to take universal, some type of precautions with every patient with respiratory stuff. And unfortunately, I think that time is rapidly approaching. You know, right? I mean, so the CDC stuff is going to be rapidly become relatively worthless, right? So.
Part of it has been the volume of information and trying to balance, you know, providing the appropriate level here.
Right. I mean, I just.
You know, you're hitting it from all areas.
Well,
You know,
the state EMSA went positive with their COVID site, right? They just put,
What's
State
that?
Emergency Medical Services just put out their
Yeah, as a matter
website
of fact,
accessible, and
as
probably is.
Jared, I think will be, if he hasn't already, will be forwarding their link to all the fire chiefs and EMS agency heads, so that you got, it's a, EMSA put out a link that is a daily update on COVID-19 and resources, CDC updates and so forth. So it's probably the most up-to-date information that we have available. We'll provide you with a link so that you can look at it on a daily basis.
There's also a source document by sector, so hospital, pre-hospital, business, education, with links that I can provide to you if you haven't gotten it already. That's a good, useful one too.
I mean, this is a critical use of the Mohawk, is really why it's there, and how we collaborate to work together to find caches, because there's all kinds of different stashes of PPEs, and we're all hoarders by nature in some respect.
Yeah, the local process, you know, is our primary concern, because we do have the option to reach out to the state, but everyone else is. There's a process, and they're going to want to ensure that we can prove we're using what we have. So, but we're definitely poised to do that. So that's why we're probably every end of the week we'll be sending out a new poll or a request for information for all the first responder agencies or EMS system providers to, you know, let us know what your current situation is.
So is this going to become similar to a chem pack, and we've got medications in places just in case of toxins? Is there hopefully a move forward with OES and coordination with the stakeholders to maintain a central supply? Sustainability for individual providers to stock $100,000 worth of equipment that has shelf life on it is much better managed from a regional perspective than individuals.
Yeah, like every county, they do have a stash of supplies, sometimes in multiple locations. So some of it is expired, but CDC and IASH are issued guidelines to use certain expired PPE. So we'll be procuring that first through the local channels, and then asking for state help if needed as well. So it'll be the next several weeks. That'll be our primary concern, probably.
And as you know from the emergency dispatch protocols, we've worked in screening questions for travel and other risk factors for COVID-19, such that we can notify EMS crews and first responders of potential increased risk before they make contact with the patient, so that they can don appropriate PPE, as well as notify the hospitals if they have a patient coming in who's at higher risk, so that the hospitals can take appropriate action to isolate that patient if they feel it's appropriate.
And it's important to note too that the questions can evolve in a very quick fashion. So the travel question was probably more imperative a month ago, and as this thing goes on, the questions can be, modified, appropriately. So.
What are the questions? I'm just curious.
Right now,
Do you have a fever and cough? Okay.
Actually, right now it is if you or anyone that you live with traveled in the last 30 days, if so, where? And of course, there's those 5 level 2 and 3 countries identified, and that information, if known sooner than later, can be
Sacramento County, Alameda County.
So if there's a hit on that screening, what's the mechanism to notify hospitals? Because we've been talking about this, at least the SMH, I'm sure the others have been as well, to have the option. And we're setting up things for all the walk-ins to screen them before they even come through the door, and to split them off somewhere where they can all be hoarded, separate from the rest of the population. But we can apply that to incoming EMS traffic as well if we have a heads up.
The way it's supposed to work currently is that the communications center notifies whatever information they have. The providers have their information to Dawn prior to making contact and other guidelines. Then they in turn would contact the ED prior to leaving the scene about the situations they have, because they'll likely get more information once they get on scene and do a full assessment. And that's currently how that works.
Are the transporting agencies getting that information? Are you guys seeing?
We've had a couple specific examples where it has worked. In each case, information was identified, it was given to the ambulance, it was also given to the first responder all prior to arrival, and then the crew notified the ED en route for whatever information it was.
Because I've gotten a message out to all of my nurses who answer the red phone to ask the questions.
Yep.
Any fever, any respiratory, mask prior to arrival. If you don't have masks, then get one from the charge before you come in.
Yeah. Well, and so one other thing is, like I took care of someone with the flu. They came to my ambulance. They got they got a few breathing treatments en route and stuff like that. I was like, look at the ambulance crew, super high risk, right? And probably this patient didn't need that done in her 5-minute transport or what it was.
So, yeah.
I mean, I don't know if you can issue a directive that maybe we should kind of figure out a way of not doing that.
Well, one thing that we were going to ask is any time you are choosing to do that in the back of your rig, that it's stopped and discontinued prior to entering our facility. And that the patient is masked, please. And it doesn't have to be an N95, because I've seen you guys put N95s, which are yours, onto patients. No, just put a general surgical mask on if you don't have one enter. And if the patient, as soon as the tent's open, honestly, if the patient can walk, talk, and be ambulatory, they're going to tent, and if they can't, they're going to go into an airborne ISO room and never enter the department, ideally. So, hopefully it doesn't get to that point in this area, but in places that this is a problem, if you talk to the boots on the ground, this becomes a catastrophic issue if you get it in your facility and you start nosocomial spread. So you guys have to start being really careful. And I've heard folks downplay, and it's true, it's problem. It's not going to be the end of the world. People shouldn't panic. But that small subset that gets sick, get really, really sick.
So Jared, when we're looking at some of the stockpiles and putting stuff, are they anticipating the law enforcement numbers? Because we're relying on our fire partners to pull just masks. Obviously, we're not going to be carrying PPEs. That's just not what we do, but at least for masks. I mean, I know with our agency what we've done in the chief's meeting is tomorrow, so we'll be talking about this.
Yeah, the information was sent, law enforcement is first responders, so it falls under all of that purview. So I've been sending it, I believe, to the law chiefs to make sure that they're included. And if they do have, we do have a large stockpile currently of the surgical masks. So if that's something that is needed, please submit the resource request so we can turn those around pretty quick.
Okay.
The N95s, a little bit different story. There's an expired cache. We're trying to determine how much and then what we can get from the state.
But law enforcement might need some education there, because probably the mask and airborne spread is like the least of anyone's problems, right? It's all phone lines.
I understand that. We still have to do our job. We're going to be exposed first. I mean, that's a very harsh reality for law enforcement. But luckily, most of them are healthy, and they won't be the extreme, part of the bell curve that gets terribly sick.
And on the
obviously, we're talking about it because what happens when you're large part of your
Yeah.
agency becomes infected.
Right.
And part of the, on the EMS dispatch side, that includes law, so the information received, you know, would go to both law and fire or first responders at the same time, so we'll continue to, you know, QI things if they don't work, but a couple examples that we're aware of did work as designed, so. Because the primary concern is just, you know, information and, you know, protection of the responders, so that's what we're focused on right now.
Jared? So in Kirkland, the city purchased a motel for quarantine and isolation of the 25 firefighters who were exposed. Does the county have any plans to establish an isolation and quarantine facility for first responders?
The health department stood up their DOC, you know, recently. That would probably be a public health discussion that will be coming out soon. Obviously, your COOP plans, I think the suggestion was to review your COOP plans on an internal basis and ensure that those are up to date and you got your continuity. But I haven't heard anything specific on that yet, but it may be forthcoming.
So what we're doing internally, we're giving our employees two options. The CDC is recommending or saying that it's okay to quarantine at home. For those personnel that do not want to do that for whatever reason, we're going to be renting a travel trailer, housing at one of our stations, and that's where we'll go.
Okay. Yeah, information, yeah, send that along. Just for our FYI would be great too. And what other people are doing.
And I think the concept of self-quarantine, I think, is important to remember, not just for personnel, but also for patients who may be contacting 911 because they're worried or scared, but well. And in general, those patients and the community may be better served with reassurance and not bringing them into the emergency department where they could potentially expose others or get exposed themselves. And so, you know, as providers, you do have the ability to assess a patient on scene, and if the patient doesn't need to be in the emergency department or doesn't need urgent care, and if the patient is okay with staying at home, then that's appropriate. And then the other thing that we already mentioned was just as far as interventions, obviously like CPAP and NEBS raise the risk significantly of transmission, and so patients who are in profound respiratory distress, intubation is probably a better tool to use than those adjuncts.
Even that's high risk, right? Because the bag valve mouse don't have viral traps, right?
Right, and right, it's true, but you know, safer than CPAP.
I
Right.
think the easiest one to stop is the NEBS, though.
What's
I
that?
mean,
Yeah,
just
right.
stopping the NEBS is
Right.
going to save you guys hugely because you really don't need them, and definitely stop them before you leave the back door of the ambulance.
You seem to be very firm on this part.
I am very firm on that because we just had one come in yesterday. It's like, you guys,
Look
seriously.
down the hallway.
You're watching mom, cancer patient, pregnant patient all be exposed potentially.
Did the crew alert you guys that they were doing a med dev en route at all?
You know, let's just say that they had, quote, excluded COVID because of lack of travel history, which is no longer a person.
But they didn't tell you that they were med deving the patient at all?
Completely unclear at this point. So the bottom line is don't enter with the NEB in progress. If you have to bag them, we understand you can't, you know, stop that. Just stop the med nebs.
Or any.
As you're discussing though these alternative plans for low-risk patients, perhaps we can consider whether or not we want to expand that and do some things like they're doing back in Jersey and other places where they're utilizing that community contact that the paramedics have for these low-risk worried folks, and you know, consider whether you want to implement, if they meet criteria, kind of base consult with criteria for who gets a swab and doesn't go in, because that's usually the worry, right? I want to be tested, and the hospitals aren't testing outside of the Monterey County Public Health criteria. Monterey County Public Health has 200 kids before they landed 24 people at a Silomar that have to be tested every few days. So they're going to rapidly deplete their stores. LabCorp and Quest both have labs, but there's nobody to collect the specimens. And so, you know, teaching the patient how to do it themselves is what they're doing in New Jersey. Go into a bathroom and bring it out, hand it in a bag to the medics, and delivery, and following that up through your public health department is one of the things that they think is gonna really be effective at limiting exposures in the emergency department, but getting that public health information and that screening done that you need. So pulse ox, respiratory rate normal, no severe symptoms. They basically show them this little, they have them upload this little video on how to collect the specimen, go into a locked closed room, collect it themselves and bring it out in a bag, send it to Quest. And you can do that under a standing-based physician order or medical directorship order. If you work with the public health department, they can follow this up.
I think, I don't want to speak out of turn because we haven't discussed it fully yet, but recently, because of the state of emergency that was declared for the state, there is an alternative destination authorization by EMSA, so it's something we could explore, but we definitely would need to start looking at those options probably sooner than later.
If the transports though are questionable, if you think the patient might be able to stay at home, just give us a call on the med consult phone, because we can talk to the patient over the phone too and maybe come up with another plan if they maybe don't actually, don't need to be transported, just not to expose other people, make sure that they're getting care, but to kind of try and limit exposures.
But just so you guys know, there really is, if you don't meet criteria, there's nobody in this county who's really doing testing. So the private offices don't have protective gear to do the testing. The health department's highly restricted. LabCorp and Quest do not have the capacity to do the testing. All area hospitals, partially related to just capacity with other patients and resources, and the fact that we also don't want worried well to come in and infect our patients, have opted not to be testing sites at this time, and there's no drive-through or other testing available in this region. So if patients just want to come for a test, unless they meet strict criteria, it's not going to happen. And this is one of the ways. We had one of our docs who actually tried to get a firefighter from out of the area tested that potentially was an exposure, and our health department declined, so we actually set up a home testing for him and had one of his buddies pick up the sample, because that's the only way. But that's what outpatient docs can do, and it has to be home testing.
And that's, I agree that that's a message that can be helpful at the scene when first, responders or medics are encountering patients, to have that discussion that, if your main concern is could you have COVID-19, what to expect if you decide to go to the emergency department. This is currently not something that the ED is able to arrange to have done in patients who are well or considered relatively low risk, and so it saves them a trip. It reduces potential transmission, and maybe there's other avenues that patients can get tested if they're concerned.
Right now there's not, though, unless you guys want to help.
Yeah, wait, how'd you get the patient tested? Through the county
It's an
lab, or?
outpatient doc. So
Yeah.
it's one of our outpatient montage docs who also works in the ED, and he
Okay.
called county and county declined
Yeah.
because the patient did not have a fever as a component. Now, 50% of patients don't have a fever
Right.
upon presentation, so it really shouldn't be an exclusion
Right.
criteria. So what he did is he instructed the patient with the video that they had
Yeah.
out in New Jersey how to collect the specimen. He sent over, and they laid at the front door, one of his firefighter buddies, the bag.
Okay.
And the patient went in and did the swab, and they put out the bag, and the firefighter buddy dropped it off at Quest.
Oh,
It's
so they
Quest
use
and
the
LabCorp.
private lab, okay.
Yeah, so Quest and LabCorp, if we decide to do this, have swabs available, and we can do the orders and generate it, and probably do a huge public health benefit. If you guys are willing to bring in specimens on these low-risk cases, you would just have to coordinate then delivery of that information to public health and see if that Marino can get it done. But right now, nobody's being tested, there's no surveillance, so we have no idea.
Jared? With the state coming out with an alternative destination, that appears to be maybe one of our higher priorities. Put up some screening tents and done their due diligence. But how do we get these people corralled, and what can this body do to help that work out?
Well, an alternative destination procedure would be something, it would be a lot of work to try to figure out and coordinate. So I think if we are interested in that path, we need to probably look at that, like I said, sooner than later, because currently no cases here, but that may not be the case forever.
And it also ties into behavioral health and other opportunities to really hospitals work together to determine if there's going to be a centralized facility that's going to be the primary receiver?
There
for
will
COVID?
not be able to be a centralized facility. If
Yeah.
if this comes out, you'll be just like they are in Washington, where every single facility is basically procuring their OR, their PACU, and every other place, and cornering off huge COVID wards. All functions of the hospital will stop outside of this in most cases. If it really becomes real, like it is in Italy, it'll be disastrous. You'll
But the
be
fact
running
is-
ICUs in the hallway, and you'll be having to decide if you're splitting vent circuits on similar sized people to try to intubate more people.
So Jared, I do have some concern about, we
It's
need to
true.
set up a procedure
If
to
it is
test,
Italy.
not just public, but the health department, public safety people. Because especially like the firemen, they're dealing with the most vulnerable population and the nurses and the doctors, and if we don't have a way to test, we could become spreaders of the disease, the harbingers of COVID-19 ourselves, because for the firemen and the police officers, and most of these people, they're in shape, they're not that risk population, but they're dealing with the risk population.
I think, as I mentioned, the health department DOC is, I think it stands up today at noon, and there'll probably be more information coming out as to these, initiatives through public health and the health department as a whole. Christy?
The people that are Asilmar, do we know if they're gonna be transported by our local transport agencies, or do they have their own transporting?
They have, so that is a CalMat team that is set up, so no, not our system responders will be part of that, and that the destination will be done by the state.
Okay, how will they know, like, I just wanna make sure if they are coming to my facility, I get a call, like my ED
Yeah,
gets a
there's
call.
been, unfortunately, there's been a communication lag with the state in the operational areas. So what we do know is that, there's, I think, 3 or 4 at the Asilmar Conference Center. And they're, I think, on a 14-day, they're going to be tested, and possibly as short as 7 days, depending on those results. And they have some state resources there on site for transport, and destination decisions will be done through them. They're supposed to notify the OA of the operational area as these things occur. So, that hasn't happened great in this instance, but we're opening up our own communication channel so that we're a little bit more ahead of this stuff.
Have you guys been invited to their planning meetings?
The EMS agency, no, but the health department was kind of as this was occurring. So
I think it kind of took us all by surprise.
yeah, you're not the only one.
So
They're
the
sick, do they have, what
I-
level of care do they
I
have?
think they're asymptomatic, is the information I have.
Take this and this.
So they're being tested as asymptomatic risk, but not likely to actually be infected. But, so that's, like I said, the current information I have.
So Jared, I got a question. So are we going to get phone calls, or are we gonna have the ability to have a conference call with the health department once it does hit? Because it's already hit in Redlands, and the 2 firefighters that got exposed, they gave them the options. You can go home, or you can, we can find you a place. They put one in a trailer, and the other one, his wife and kids went. But by the time they got notified, they were already off duty. It wasn't until the next day, around 2, they got notified that guy you brought in is full blown.
Yeah, I think there'll be more information coming out of the health department, DOC, shortly. So, we're involved in that, many other stakeholders, so that is part of some of the stuff we're talking about, so.
There are a series of planning meetings. One is happening right now.
Yeah, we're not there.
We've been
We're here.
participating.
And we're here.
Yeah.
Yeah. So we will catch up on whatever happened at the meeting this morning. But yeah, we've been participating, and we, as we get the questions, we bring them to the table.
Okay, thank you, Jared.
Okay.
Let's move on to EMS System Quality Improvement Program, CQI TAG. Tom?
I do have a cache of toilet paper if you need some. I'll let you know that. I'll help you out wherever I can.
You're my new best friend.
There you go. All right, so on the CQI tag, got a couple items here. membership into the CQI TAG committee. Laura's been reviewing membership and is doing the housekeeping and cleanup in this area, making sure everybody's memberships are some are going to expire this year and some are next year, correct?
We're asking everybody to have a letter from their employing organization naming them as a representative or alternate to all of the QI committees. This has not been done in these committees before, so what we'll do is half of them will expire in 2021 and half in 2022.
All right. Update on airway measures. We're just really hitting hard on making sure, as an EMS agency, that we're ensuring that we provide accurate data and that is presented accordingly. So by May 12th, our next CQI TAG meeting, we'll be able to have a complete report in the advanced airway measures. Moving on to metrics, in 2020, the EMS agency is working on indicators to collect, and we're also we'll present those measures and how we're going to collect that in the May 12th CQI TAG meeting. We also reviewed bradycardia and tachycardia protocols. The EMS agency is working on these two protocols, and we'll present a draft form to CQI TAG, and then we'll present it to committee. And the last thing that we're looking at right now is documentation. Really important. It's one of the first steps in the CQI process as a system-wide. So we want to make sure our documentation is good from the field providers. So we're going to be looking more closely into that this year to ensure that accurate information is being presented on those PCRs so that we can collect our data appropriately. And that's all I have. Any questions?
Thanks, Tom.
Thank you.
Next up is STEMI, QI committee.
So we received word from the state that our STEMI and stroke plans were both approved, so that's a good thing. There isn't a written report for STEMI and stroke because we just met yesterday. So some of the things on STEMI, we are having a membership discussion at all of the QI committees, and what we want is the committees to have full representation while still being small enough for us to be able to work. So I'm taking input from the committees on who needs to be added and how we need to tweak the membership to best meet the goals. We are also talking about the ESO data fields that there are a number of differences between organizations in what data fields they have in ESO. So we discussed putting together a group, and it'll be a very small group, one from AMR, one from a transport ALS provider, and one from non-transport ALS provider. And we are going to go through every single one of the ESO fields, decide how it's configured, is it turned on, turned off, is this mandatory? It'll be a fairly long process, but I think it's very necessary. We are also talking about in running data, using ESO, if the paramedics suspect a STEMI, please put that as your primary impression. I see it sometimes as chest pain or abdominal pain, and then under signs and symptoms it says STEMI. It's very difficult to query that, and if you put it as your primary impression, it makes it much, much easier for us to be able to collect the data. With stroke QI, I'm just going to move right ahead to that one. The biggest discussion is we want to come up with a large vessel occlusion scale for it to be used countywide. So we had quite an extensive discussion on this. Some of the concerns are cost, training. We're looking primarily at two different scales. One of them does come with an 8-hour training and a $15 cost. The other one has less training and no costs. So I'm going to be taking a deep dive and looking at the difference in accuracy between the two scales and bring that back to the next stroke meeting.
This is a pre-hospital scale to determine for large vessel occlusion?
Yes.
And then what are you guys going to do with that information?
Pass it. The idea is to pass it on to the stroke center, and the stroke coordinators have said this will be really good for them. It gives them a heads up. If they have a very high scale indicating a large vessel occlusion, they can contact Stanford or Good Sam or whatever comprehensive center they transport to early on and shave a few minutes off
Okay,
of the time.
I guess I'm not too educated on that. I mean, has this been validated that this works?
So
The LVO
it's-
scales?
It's validated to work, but generally speaking, used in areas where diversion is based on positive criteria to a primary center. So at this time, we have no protocol to basically change what we do for
Right.
potential pre-hospital positive LVOs. So if cost and implementation are something that's
Yeah, I
difficult
mean-
at this time in the current setting, it may not be
I mean, I don't-
reasonable to delay
right.
slightly.
Yeah, if we don't have a neurointerventional center in the county, they're gonna end up at one of the stroke centers and get transferred anyhow. It might
Because they're
not be that
going
useful,
to
yeah.
end up getting a CTA
Right.
and called simultaneously, so I'm not sure how much time it saves us.
Right. I would just try to imagine that, yeah, we got an ambulance coming and, you know, I mean, like, there's no way we're gonna get that started before the patient's there, right? I mean,
According to Monty, the scale is pretty much identical up until what you guys would do in the hospital. Like,
Right.
we would just be
I mean-
assessing
Yeah.
the same things that we're assessing now, with the addition if something came up. But like he said, there was no change,
Right.
especially in the small time
I mean-
frame that we spent with the patient on scene.
I mean, you guys have so much on your plate in
It
terms
might
of
be a lot of
training and issues. I mean, this
cost
just
and
seems
effort
like,
to do this.
I mean, probably not.
Probably
worth
not a
it.
high priority at
Right.
this
I
moment.
mean, right,
There's
probably
a whole bunch of
not
other
a
things I'd
priority.
rather have you do, like stuff and nets.
Yeah, right, right. I mean, like, this just seems like, you know, right. I mean, the idea is to get the stroke patient to the hospital, right? So, you know, right, this doesn't seem like.
I think what they're envisioning was just being able to pull the trigger on getting air medevac to the site faster in anticipation of transporting these patients to a definitive center that can do
But
thrombectomy.
are they,
But I don't think-
did Stanford or regional agree to launch based on a field LVO scale that's positive? I don't believe so, because you haven't ruled out bleed or things.
I mean, what, I mean,
We
has
still
any
need-
other
we still
system
need to
done
work
that?
up at the facility. yeah,
Right, so I
think-
don't see this as being something that's a huge time saver
Right.
at this point.
I mean, like, so.
If we had a interventional program in the county,
Right.
then diverting an LVO positive patient makes sense, because you can go directly from the field, but you guys have to decide where your resources go.
This was brought up by the stroke coordinators, and they're quite firm in their belief that we need to be doing this.
Okay,
These are not
so wait,
operational.
who's the, I mean, so you mean Monty from our hospital? Okay, we will talk to Monty, I don't, because this does not make sense.
Well, I'm not trying to throw anyone under the bus.
Right, no, but I mean, I mean, you got someone who has no operational experience with EMS or anything like that, I mean.
Well, but also
right.
Byron at Chomp, who does have operational
Yeah.
experience with EMS
I mean,
and
what,
is
I'll
medic.
deal with Monty.
And I think, you know, Byron is hopeful that maybe we can take this information and work with the centers, or if a local center becomes interventional capable, that this training will already be done and will have the enhanced capacity. I think right now you guys have
Yeah.
probably bigger fish to fry,
This is-
but, I mean, it's certainly something if you have openings and have the money and funding and the time to train, it's a great thing and it'll give us more information. I don't think it's a critical thing at this moment.
Right, but is the idea for the future that you would call a helicopter and then fly that patient directly to a interventional
No, I
stroke
don't
center?
think that's the.
I mean, right, so I don't know what, right, okay.
Yeah, apparently from what the stroke coordinators have said, this is, at the International Stroke Conference, for example, this is becoming more and more of a thing for pre-hospital. Like I said, I agree, this is not as high priority as, say, COVID-19 discussions.
Well, it certainly is becoming the standard scale in centers that have the option of a interventional stroke center versus non-interventional stroke center. It's a critical component. And that's
Right.
why at the national level, this is so important. For our system right now today, unless you're gonna do field diversion because of a positive LVO scale, out of the county to a primary center,
No,
this
it
does
won't- it
not
won't
seem
change destination.
like it's a critical pathway, because they're still going to want imaging at our facility. And to ensure that we can't manage that case before they'll take it.
Okay, some other stuff going on is discussion of, the same discussion of membership and standardizing ESO fields. And if stroke or TIA is suspected, please put that as your primary impression. And please do a complete BFAST and document it in the section in the PCR that has the whole BFAST. What we're we're seeing, and it's not frequent, but we are seeing they'll fill out a fast on the PCR, but leave out the last known well time, and that's buried somewhere in the narrative, and that's really probably the most important, single most important piece of information that you can pass on. So please remind your crews to do that. On to T-Quick. Any questions about stroke or STEMI? Okay, so T-Quick, there is a report, again, reviewing membership in the QI committees, and polling everyone in T-Quick to see who needs to be there. It's been suggested to include a representative from Hazel Hawkins, a representative from San Benito County EMS Agency, and the CES coordinator for AMR in Santa Cruz and San Benito counties. I think they would be very helpful in determining this. Apparently about a third of the trauma patients from Santa Cruz come to us, is what I was told by the CES coordinator. I was a little surprised it was that high. The EMS agency and our data collection on T-Quick, on trauma data, I'm trying to better define step 3 and step 4 patients. The step 4 patients definitions aren't going to change destination and aren't particularly applicable to the field other than identifying it as a step 4 patient. But the step 3 patients, there is one piece in CDC criteria that says vehicle telemetry consistent with high risk of injury. And that's a lot of words that says nothing. So I'm trying to narrow that down and try to match it with Natividad so that we get the same thing. That one does affect the field simply because the difference between a 3 and 4 patient, step 3 and step 4 patient is destination. Step 3s do need to go to a trauma center. We just put the traumatic cardiac arrest policy into effect on January 2nd. Please remind crews that epinephrine is really rarely used in a traumatic full arrest. And there was a discussion about how long an EMS crew should wait at an LZ for a helicopter to arrive. Apparently there was a call where they waited 30 or 40 minutes for a helicopter, and this was discussed at T-Quick, and the word from Natividad is, if you're waiting at our helipad, don't wait and don't ask permission, just go to the ER. That Natividad will take these patients. Please give them a heads up. Don't just show up in the doorway with, hey, we got a trauma. Yeah.
Can I add to that for a second?
Sure.
So I really appreciate the willingness of Natividad to re-educate or educate key personnel in terms of understanding our boxes, and I know it's a work in progress, and I appreciate that. I was trying to think, how can we develop kind of a field mechanism that works 100% of the time for field providers? Because in spite of our intentions, over a 3-year time span, this continues to happen. So what I was thinking, and maybe this can be discussed at EMCC, is what if we have something in a policy that says, if for whatever reason, Natividad will not accept a ground pediatric trauma patient, that by protocol, you can divert to SVMH or trauma?
First off, we can't write a potential EMTALA violation into our protocols.
Well, a potential EMTALA violation occurred last month.
I listened to the recording on that. That is an incident under investigation. We can talk offline if you'd like.
Yeah, I'm just talking pragmatically, and there has to be a way when an ambulance is intending to go to Natividad with a pediatric trauma patient, there has to be a bulletproof mechanism for that paramedic or that crew to have a destination. And if there's confusion at Natividad, which there has been consistently over a 3-year time frame, we have to know what to do. And all I'm saying is, go too deep, have a too deep policy, or if Natividad does not work for any reason, you can divert. That's all I'm asking.
Eric, those are conversations that we're having internally, especially because we have reviewed the UOs, and we are currently under investigation.
I understand, Teresa, but these conversations have been occurring internally for years.
Well, no, I can only speak to the conversations that I have been involved in.
And I provided you with
have,
correspondence.
You did.
Demonstrating that this is a multiple year problem.
Let's not make it any more complicated
Okay, no,
than
we're
it
not
needs
trying to
to be.
make it complicated. Give me 1 second, please. We did review 4 cases from 2018. 3 involving one of the hospitals. Each of those was addressed. Protocols were drafted and implemented after that. So from 2018, I believe the last one might have been in October, to just last month, there have been no UOs reported of cases of
That
they
does
were
not mean
described.
cases had not occurred. It
Well-
means no UOs were reported.
Well, we can only do something about the things that we know about. And so we can only judge by the number of UOs that we received. So we addressed the ones from 2018, then we saw nothing from 2018 to 2020, last month, and we are investigating that case. It is our plan to address it, and address it with the hospital. So it is not that we are not doing anything. We would love for everything that we do to be able to put systems that are, 100% foolproof, but, those take time and not, I don't know that we can always come up with one, but we are working on it. What we are saying to you is that it is not that this is happening every day. We are addressing the issue and we are working on it. We appreciate your feedback and we are listening to your feedback and we are discussing the options.
As I mentioned, I'm very appreciative. Dr. Click has been extremely willing to address this issue. Julie Ramirez, Dr. DeStanti. The problem isn't a willingness to do it. It's the fact that because of the trauma team that circulates in and out of the hospital, because of a large volume of ED physicians, some of whom are knowledgeable with EMS policy and protocol, and some of them aren't. I deal in reality, and the reality is this consistently happens. UOs are not going to come from AMR. I can't be responsible for researching all of the events that I know have happened
Well,
that have not generated
that's
a UO.
information that we need to know. If something like that happens, that there should be a UO filed with the EMS agency.
I can't do UOs for AMR. I don't work for AMR.
But we're not aware that.
I've submitted UOs regarding it
We are getting-
when there has been issues on the radio. And I get it, a report from the crews. So in the past, and Dr. Click again has been helpful with it. In the past, it has been issues with nurses trying to give orders or trying to tell us that it's not a trauma alert. And those have been submitted as UOs each time that I become aware of them.
We're at a point now with the protocol where don't ask permission, just bring the patient in. So if they don't, and basically if it's a box 1 or 2 where they're refusing transport out of the county, that basically is on the protocol. It says just bring them in. So don't ask permission, just bring them in. Because it's, as a county or as an EMS system, we've decided that it's better for trauma patients to end up at a trauma center than the non-trauma center, even if they aren't willing to follow the protocol. It suggests going to a age-appropriate center. So just have your providers just bring them in.
Eric, and I agree with you that making sure that as you have staff turnover, that the new staff are trained, that is very important, that is key, because that's sometimes where the information is falling through the cracks and the protocols are not being followed consistently. So it has been identified by you, by us, and so that's something that we need to do something about.
I just don't want us as pre-hospital providers to be in a scenario where, in the interest of providing the best possible patient care, we go to a facility that we're not allowed to go to.
And we don't want you to be in that position
And it
either.
generates another investigation of paramedics in Monterey County. I do not want that to happen.
We don't want that to happen either.
I can also state that the times when I've looked into a UO where I've been told that the hospital is refusing the patient, I listen to the tapes, I've never heard a refusal. I've heard encouragement not to come to them, or, this patient would be better served by a pediatric trauma center, but I have never heard a refusal. If they give you an order to whatever the order is, to go to a pediatric trauma center to fly the patient, and you say, okay, hang up, and the parent later refuses, you can't say that Natividad refused the patient, because they didn't. They didn't have all the information. They need to get all of that information.
I will say though, in those cases when the doctor or the nurse is suggesting on the radio, that comes across as an order, and that's quite subjective too, remember at the time. So if they're suggesting they cannot take something, then that means you take them somewhere
No,
else.
it's not. That is,
Well, Laura, that's semantics.
All right, I'm gonna stop the discussion right here, because a lot of this is stuff that we should be talking about offline, and I completely recognize your point, and just from my standpoint as the EMS Medical Director, if there's a situation in which you have a pediatric trauma patient that needs to get to a hospital to be stabilized, and you don't have an opportunity to get that patient emergently to a pediatric trauma center, because for whatever reason you're waiting for the helicopter, you're staging at a landing zone, you go to the trauma facility, you go to Natividad. If you get pushback from that, you bring it to us, we will address it. We're not gonna hang paramedics out to dry because they're trying to do what's best for the patient. I think from a practical standpoint, that's what you're asking.
Correct.
And I will tell you, as the medical director, I will always side with what's best and safest for the patient. And we will deal with the politics later.
And the EMS agency does not want to do that, what you are saying. Our goal is the treatment of the best treatment for the patients. Just what Dr. Burley said.
Thank you.
okay, the last piece on this is our base contact policy says that, that paramedics should make base contact for step 1, 2, or 3 patients, and I'm going to be changing that to notification as opposed to base contact. Thank you.
Thanks, Laura. The next item on the agenda is reports, and that's emergency communication drill reports with Jerry.
So these are just standard reports we bring to every MAC meeting. I can entertain any questions related to the emergency communication drills. They remain mostly consistent. There's a couple, issues each month with different facilities, but overall, one of the things I did want to talk about was most recently we've started doing bed polls for isolation rooms, and that as a result of the region trying to find destinations for the Princess Cruise nightmare. So I do appreciate the facilities for being very responsive with that. So we haven't had any issues, and we've been able to report that stuff up to the state. So another good use of the ReadyNet system.
And then next item on the agenda is ambulance patient offload times.
So the EMS agency is now reporting APOT times quarterly to the state. So in the packet is the what was most recently reported for Q4 2019. Basically, the first chart shows you the number of transports. Second chart shows the times per hospital for each month. And the take home from this is we don't have an APOT problem here. On occasion it happens, but for the most part, this is we're doing really well on that, and I'd like to commend all the participants for their diligence in keeping this to a minimum.
Do you have an average time number that we could wrap our brains around for APOT?
I have I have it by hospital, so you know what, Jared, are we able to pull that up on the screen?
Because we indeed are a fortunate county.
We are. I came from Riverside, and it's in the thousands of hours per month. That was crazy.
I think Chomp was like 15 minutes.
Well, what do we have? Chomp is,
15 minutes.
yeah, Chomp is under 15 minutes. Me is under 10 minutes for the most part. Natividad, 17 to 19 minutes. And Salinas Valley, 17 to 21 minutes.
We're doing great.
Yeah, no, and it's not to say there aren't the occasional outliers, but for the most part, this is pretty good. And this is 90th percentile.
Is this an average or a-
No, it's 90th percentile.
Well, we'll see if that holds true through our COVID epidemic.
That was my question. It would be interesting to see if we have decon issues that drive these up a little bit. We'll be watching it.
So that brings us to any future agenda items. Yes.
Just a kind of a request as we start looking at reviewing protocols for the next protocol cycle. Can we take a look at the crush injury protocol at some point?
At which
I don't-
protocol?
The crush injury protocol. I don't think there's anything, earth-shattering that needs to come up right now, but there've been enough questions from providers in the field. I'd like to put it on the schedule for whenever it comes around.
Okay.
That's been rolled into the major trauma patient policy, so you just want us to discuss that piece of it?
Yeah.
Okay.
So, regarding me and Dr. Quincy's concern about the nebulizer and, and stuff like that, is there a way to, like, have an emergency, something go out from you or something
We can
like
put
that?
out some communication
Okay.
to just remind folks that that increases transmission risk, and
Okay.
things like CPAP and nebulizer
Okay.
are generally
Okay.
better avoided.
I'll send
Rather than-
correspondence out to our crews as well.
I
Okay.
mean, just the key of discontinuing any, prior to leaving the back of the ambulance, and masking would be huge, because, we have people coming in, it's like, well, they were vomiting in there, so I opted not to put a mask on, or whatever, and it's like, well, as soon as they're done, just stick the mask on, they can vomit, or freaking easy.
Well, I'll tell you, like, from our last correspondence with Christy, we ordered more surgical masks, and that was put out there that anybody
Awesome.
with cough, cold, mask.
Awesome.
For sure. But I'll update about the nebulizers.
And we know that you guys have some limitations, so definitely just go to the charters, they have a little stack of surgical masks for you guys, or you come in as long as the patient's stable.
And I'll remind folks that if they do come in on a nebulizer, just to, stage at Dr. Kalinsky's desk and.
Yeah, right.
It wasn't me, it was
Everyone
Rory.
breathe
Rory
deeply.
was like, seriously, you guys, can you fix this, Michelle?
And just so you know, I put out to my comrade to please put a stanchion at the EMS entrance with masks to try and make it easier for you guys.
Immediately all robbed.
Yeah.
Gosh, you guys.
So you might need it, right.
It's locked, okay? Hopefully they won't or something.
You tried to star 911?
So that brings us to any announcements?
Wash your hands.
Wash your hands. I'll be giving a EKG lecture on April 14th at 12:30. I believe that'll be here. And I think we've tentatively titled that "Feeling Better but About to Die." So should be interesting. Any other announcements?
Dr. Rubin. I just wanted to thank Scott and Celine's Fire for the ESO Solutions. You guys are co-hosting that on May 20th. Have you filled every class?
Got about 10 spots left.
Okay. It's just a one-day ESO Solutions event. If you want to have, you got 10 spots left, so maybe if you can get in there. It's going to be held at the L. Gatlin Library in Salinas. It's just to help out with the PCR, EPCR stuff. They're bringing in a couple of people from ESO.
Yeah, so the goal of the class is to address analytics and ad hoc so you can build better back-end reports. Went to the Wave last week and Laura was there. We got a lot of good information. Will and Ben were there. But having more local focus, because you can build ad hoc reports that are especially identifying our targets, but we don't know how to build them.
So I would want to thank you guys again, Salinas Fire, for hosting.
Any other announcements?
We have some cardiac classes, a series of cardiac classes that we teach every year, several times a year, by Jen Carlquist, one of our PAs, who's works for Central Coast Cardiology and for our emergency department. So I'm going to forward it to the EMS, to Laura, Steve, and you guys, and that way they can kick it out to all the providers.
It's an
You're
excellent
welcome.
class.
Yeah, they're great classes. They fill up fast, so get them out here.
She does an amazing job.
She does, yeah.
Yeah.
Great. And our next meeting date is going to be May 13th. And with that, we'll go ahead and adjourn. Thank you all.